discuss on the topic myocardial viability. Definition: viable myocardium. Myocardial viability refers to ischemia-induced dysfunctional myocardium that is still alive, that is not irreversibly damaged, and has the potential to recover contractile function after restoration of the adequate blood supply, that is revascularization. If we see the pathophysiologically, then the cardiomyocytes that are alive defined by the presence of cellular, metabolic, and microscopic contractile function. So viable myocardium has preserved wall thickness, preserved contractile reserve, presence of active metabolism, and absence of transmural scar. So basically in myocardial viability, these two definitions are very important. That is, one is stunned myocardium and second is hibernating myocardium. So stunned myocardium, these both are examples of viable myocardium only. Stunned myocardium is the myocardium that is in the setting of brief ischemic insult, that is transient post-ischemic ventricular dysfunction that persists despite the restoration of the normal blood flow. And repetitive ischemia leads to chronic stunning. And second is hibernating myocardium. So that is again a viable myocardium, but that is in the setting of a chronic ischemic insult. So there is chronic yet reversible contractile dysfunction resulting from prolonged reduced coronary blood flow. So that is, hibernating myocardium is basically an adaptive downregulation of the myocardial metabolism to match the decreased oxygen supply due to the chronic ischemic insult. So basically in myocardial ischemia, whenever there is an intermittent ischemia with reperfusion relief before the necrosis occurs, so this is basically a brief ischemic insult, leads to myocardial stunning, and that is a spontaneous, it leads to spontaneous recovery of this dysfunction in days to weeks. Second is, if instead of a brief intermittent ischemia, if there is a chronic moderate ischemia, then it leads to a metabolic adaptation which is called as the hibernating myocardium, and this will recover only after revascularization. This will not recover spontaneously. So in myocardial stunning there are no histological changes, while in this there is dedifferentiation of cardiomyocytes. And in case of myocardial stunning, if there is repeated episode of stunning, then again it leads to a hibernating myocardium. And another one is that if there is a severe ischemic prolonged ischemia, and which is severe, then it leads to necrosis leading to myocardial scar, that is replacement fibrosis, and this is an irreversible dysfunction, while these two are still reversible.
Is there any period for validity? Myocardium? Whether within 1 month you can open the stenosis?
If basically that is what we do, that is post PCI, that within 3 months we check for the EF function. So if that is a retrospective study, so if it was a hibernating myocardium, after revascularization it would have been improved. So there is no specific time period, but everywhere it is written in that is 1 to 3 months, that is what is mentioned here. Because this all depends on the collateral blood supply also and other number of other factors also which are not easily visible. So this is basically a graph showing myocardial stunning, that there is a sudden reduction in the coronary blood flow, that is this fall, and after which there is a brief episode of ischemia of minutes, and then there is again a restoration of the blood flow. So this blue line is showing the blood flow, and the contractile function, which also dropped along with the decrease in the blood flow, will now gradually improve after few weeks, that is after few days to weeks, once the restoration of the blood flow has occurred. So this is despite the restoration of the blood flow, there is few days to weeks the myocardium will remain dysfunctional, and that is called as myocardial stunning basically. So this is a physiological response in which there is a spontaneous or there is a restoration of the blood flow, and the contractile muscle will recover after a few times, that is stunned myocardium. And this is basically myocardial hibernation, in which here you can see that the blue line, this is the coronary blood flow. It is chronically decreased over a long time, that is months, and due to which there is a decrease in the contractile function also. And once we do revascularization with the help of maybe PCI or CABG, then there will be a gradual improvement in the recovery of the function. So basically this hibernating myocardium, whether it is present or not, it will decide that revascularization will improve the contractile myocardium is a adaptive response of the body. So it is basically the cardiac muscles are working at a very low pace, but they are still vital. And this is
सुसुप्त अवस्था गुजरात में
so there are also certain instances where there is repeated stunning. So in which the baseline blood flow throughout is maintained, but there are ischemic events, small brief ischemic events. So this is also basically leading to repetitive stunning. So you can see that gradually due to repetitive stunning, the contractile flow, the contractile power of the muscle also decreases. So it basically converts into a hibernating myocardium. So this is showing that chronic LV dysfunction due to repetitive stunning, that is also a possibility. So every chronic is not hibernating myocardium, there can also be chronic stunning also. So these are basically the differences. That is, if we talk about the coronary flow at rest, in stunning it is normal, in hibernation it is reduced, and in scarring it is severely reduced or even absent. If we talk about the coronary flow reserve, then it is normal, reduced and absent, same in that. Contractile reserve, the contractile reserve is present in stunning as well as hibernation, as these both are viable myocardiums, and in scarring it is absent. If we talk about the metabolism, the stunning metabolism is present, hibernation also it is present, because again these are viable myocardium, it is absent in scarring, there is no metabolism in the cardiac myocyte which is occurring. Same way necrosis is present in scarring.
hibernation is enhanced.
Yes sir?
Hibernation में enhanced क्यों लगे metabolism?
So that is again adaptation of the body only. That is, if we see in the PET scan, then enhanced is basically that the coronary blood flow is reduced, but still the metabolism is present. So that is why this terminology is used. Otherwise, the basic thing is that the metabolism is present. Necrosis is absent in these both, in present in scarring, and in histopathology the entire architecture of the normal cell is present here. There is only increased reactive oxygen species, mild edema and glycogen depletion. Here there is glycogen accumulation, small mitochondria and loss of sarcomeres, which is called as dedifferentiation. And here there is coagulative necrosis leading to fibrosis, collagen replacement and non-viable myocyte. Same way, response to revascularization, so this recovers spontaneously, this recovers after revascularization, and here there is no recovery despite revascularization. So what is the importance of viability, and why do we need to know whether the myocardium is viable or not? That is, first is to predict the functional recovery. That 25 to 40% of the patients with ischemic LV dysfunction have significant hibernating myocardium. So whether revascularization will help or not. Patient selection for revascularization, whether PCI or CABG, that is more than 10% viable myocardium is considered sufficient to warrant revascularization. Prognostic stratification. Like if we get to know that there is a lot of scar burden and very less viable myocardium, then there is a high risk of BTVF and high risk of sudden cardiac death. It also helps in guiding ICD decisions. That is, more scar, it predicts appropriate ICD therapy, and there is sudden cardiac risk independent of EF. It also helps in guiding CRT decisions. That is, if there is a non-transmural scar, then it predicts a better CRT response, while the transmural scar, that patient will be a poor CRT responder. Then differentiating ischemic versus non-ischemic cardiomyopathy. That depends on the pattern of the involvement of the muscle. That is, transmural or subendocardial involvement is seen in ischemic cardiomyopathies, while if there is a mid-wall or epicardial or patchy involvement, then it is seen in non-ischemic cardiomyopathies. Next is differentiating true severe AS versus pseudo-severe AS. So basically, in AS, aortic stenosis, if there is LV dysfunction present along with aortic stenosis, then there is low flow, low gradient AS. That is, due to the LV dysfunction, we get a gradient which is lower. So generally, a dobutamine stress echo is performed in this type of patient to determine whether that patient has a true AS or a pseudo-severe AS. So in that case, we can decide whether the patient needs AVR with revascularization or revascularization only. So that is used in the case of aortic stenosis. Same way, there is another parallel problem where viability is used that should be used, that is severe ischemic MR. So as we all know that in inferior wall infarction there is mitral regurgitation due to damage of the papillary muscle. So in that, if there is so basically that MR is a ventricular problem and not a valvular problem. So if the myocardium responsible for that MR is viable, then only revascularization is required for the patient. And if that myocardium is non-viable, then that patient requires an MVR along with the CABG, or that is maybe a valvular repair with revascularization. And in heart failure listening for patient, that is, if the myocardium is viable, it may allow recovery and there can be deferral of transplant. So that is again the use of viability. So now how do we assess the myocardial viability? So basically there are 5 tests which we have. First is echocardiography, second is dobutamine stress echo, third is SPECT, and fourth is PET. So SPECT and PET are basically parts of nuclear cardiology. SPECT scan and PET scan. And last is cardiac MRI. So this is basically the principle of all the tests which we are talking about. That is, first is if we talk about the SPECT scan. So SPECT scan, in which we use either thallium or technetium, that are basically the radionuclide which are injected in the patient. So what occurs is that this thallium, it transports to the sodium potassium ATPase pump and it is actively transported inside the cardiac myocyte, while the technetium enters into the mitochondria. So basically this thallium and technetium tells us whether the membrane function or the mitochondrial function of the myocyte is occurring or not, whether that is viable or not. So these are the part of the SPECT scan. As we know that 18-fluorodeoxyglucose is the part that we use in the PET scan. So when that is injected in the patient's body, it transports via GLUT transporter into the cardiac myocyte and then it is depleted. So this tells us about the metabolism. Next is dobutamine stress echo that we use. So dobutamine, when injected in the patient's body, it attaches to the beta receptor and it activates cyclic AMP, causes release of calcium from the sarcoplasmic reticulum and causes contraction of the cardiac muscle. So that will tell us whether that muscle is viable or not. And this is the principle of cardiac MRI. That is, we give gadolinium contrast inside the patient, and this gadolinium basically it is an extracellular. That is, it stays in the extracellular space. So if the cardiac myocyte is non-viable, so this gadolinium accumulates in the interstitial space, and which gives us an idea that the myocardium is scarred and non-viable. So these are basically the primary principles on which all the tests work. So as we saw that the thallium determines the membrane function, the technetium tracers, they determine the mitochondrial function, dobutamine stress echo tells us about the contractile reserve of the patient, whether the myocardium is contracting or not. PET scan tells us about that is 2 functions, that is, one is the membrane function and second is the metabolic function. Because as we saw that if there is the metabolic function of the cardiac myocyte is occurring, then the 18-FDG will convert into 18-FDG6-phosphate. So this conversion gives us an evidence that the myocardium has the metabolic function intact.
Conversion will give an update, or FDG uptake will give some update.
So sir, FDG entering into the myocardium also tells us about the membrane function.
Yeah, but you cannot get the FDG6B.
Yes sir, we cannot get
Yeah,
that.
so the uptake of FDG is an indication.
Yes sir. And last is the cardiac MRI, which tells us about the contractile reserve as well as whether there is scarring present or not. So first is echocardiography. So basically the principle of echocardiography is that scarring leads to thinning of the LV and it increases echo backscatter. It also helps to estimate the myocardial contractile reserve. After reperfusion, stunned or hibernating myocardium may recover its function, that is days to weeks later, So it is recommended to wait for 40 days after acute MI and 3 months post CABG or PCI to evaluate the ejection fraction.
Sir, my question answer.
Yes. And ischemia leads to decreased amplitude of contraction, delayed onset of contraction, that is tardiokinesis, or decreased velocity of contraction. So basically in echocardiography, we may not know before revascularization whether this will recover or not. That is a retrospective analysis which we get to know after 40 days or 3 months. So markers of poor revascularization outcomes in echo is when if the LV wall is very thin, which is already visualized in the echo less than 6 mm end diastolic LV wall, or the LV end diastolic volume is more than 130 mm. So these two are predictors, but still they don't give us a sure shot idea whether the myocardium is viable or not. Now the second test to analyze viability assessment is the dobutamine stress echo. So in dobutamine stress echo, what we do is we give dobutamine with the dose. We start with the dose of 5 microgram per kg per minute. We increase it every 5 minutes. Every 3 minutes we increase the dose to 5, maximum up to the dose of 40 microgram per minute. And during which we take total 4 echo, that is one is the Black's view, short axis view, 4-chamber view, and 2-chamber view. So now what is the basically interpretation of the dobutamine stress echo? So if the resting function is normal, we see whether at low dose it is normal, at peak dose it is hyperkinetic. So this is a normal response, the DSE is normal. Second is the resting function is normal, at low dose again it is normal, but at peak dose there is some problem which is seen, that is there is some regional wall motion abnormality which is noted. So this indicates that there is ischemia, that is the routine DSE that we perform. Same way, the resting is normal, low dose only we start observing the wall motion abnormality, and it increases in the peak dose, then it is severe ischemia. Now, this is very important in terms of viability, that is if there is a resting wall motion abnormality already present in the echo, and we do a dobutamine stress echo in which at low dose there is improvement in the contractile reserve, and at peak stress there is worsening. So this is basically called as the biphasic response, which indicates that the myocardium is hyperkinetic. So this indicates biphasic response indicates that the patient has hyperkinetic myocardium. Same way in resting wall motion, there is a resting wall motion abnormality, there is improvement in the low dose, and there is sustained improvement in the peak dose. So it tells us that there is viability, but there is no ischemia. So that myocardium may be stunned, or there may be a tethering effect, that is the adjacent contraction of the adjacent myocardium shows that this myocardium is contracting. So next is if there is a resting wall motion abnormality, at low dose it becomes worse, and at peak dose it becomes again worse, so that is again ischemia. Resting wall motion abnormality, no change at the low dose and improved contraction at peak dose, that is again a tethering effect, that due to the more hypercontraction of the adjacent myocardium, it is visualizing that there is an improved contraction at peak dose. And last is if there is a resting RWMA and there is no change at low dose or peak dose, then it is a non-viable or scarred tissue. So basically biphasic response, as we said, that a dysfunctional myocardial segment improves contractility at low dose dobutamine but worsens at high dose. So what is the pathogenesis? That if the myocardium is hypertonic, at low dose it will contract due to beta-1 receptor stimulation. So that basically tells us that the myocardium is still viable and has a contractile reserve. But as soon as we reach the peak dose, there is increase in the tachycardia, again, so due to which there is decrease in the diastolic coronary perfusion, leading to exhaustion of the coronary flow and leading to demand ischemia. So the same segment which was contracting in the low dose now becomes ischemic and the wall motion deteriorates. So this tells us that it is a hyperkinetic myocardium. Next is SPECT NPI, that is single.
No GLS.
Yes.
GLS on echo will not predict viability.
GLS on echo can also predict that. Yes.
And abhi cut off है ना I think. Next time के
Yes. Next is SPECT NPI, that is single photon emission computer tomography plus and myocardial perfusion imaging. So this is a commonly used nuclear cardiology modality. The So this can be interpreted with rest images only or with even a stress or a testing protocol. And as we said that there are two things, one is thallium and one is technetium 99. Thallium predicts the membrane function and technetium 99 predicts the mitochondrial function. Currently, due to difficulty in availability of the thallium, technetium is more used than thallium. So basically in SPECT MPI, this is the way it is performed. There are different type of protocols in which it is performed. First is a single day protocol, stress first single day protocol, in which we give stress to the patient, inject the technetium 99, 15 to 45 minutes we have to wait and then do the stress imaging and then again review. And again after rest, that is first there is stress and then it is a rest. And again technetium is included and again imaging is done. So this is a single day protocol. Same way in a single day protocol we can do rest first and stress after. And there is one more 2-day protocol, that is in which we do stress imaging on first day and we do rest imaging on second day. So how do we interpret the SPECT scan? That is, suppose this is and stress, we can see that the entire myocardium is taking the uptake. On rest also it is taking the uptake. So there is no defect in the perfusion and wall motion is normal. This is an attenuation infarct basically, and it tells us that the wall motion, if it is normal and if there is slight decrease in the uptake, then this is an attenuation infarct. As you can see here that on stress there is no uptake, as well as at rest also there is no uptake. So this is also a fixed defect, and this tells us that there is a scar in the myocardium. And here if there is ischemia, so on rest the perfusion is normal and on stress we can see that there is some attenuation of the perfusion. So this tells us that basically this is a reversible defect. So in SPECT scan, basically there are total 17 segments which are considered. There is a short axis view at basal level, mid level and apical level. So this becomes 6, 6 and 4, that is 16 segments, and one is the LV apex, that is total 17 segments are considered. And in those 17 segments, we see whether there is normal, then it is 0 score, mild defect, moderate defect, severe defect or absent tracer, based on which we give 0, 1, 2, 3, 4 score. So total the score is calculated, that is total there are 17 segments, the maximum score is 68. So based on which first of all we take the sum of all the stress scores, that is SSS, then sum of all the rest scores, that is SRS, and then we take the difference of this, that is sum difference score, that is the score at stress minus the score at rest, which tells us about this. And we can get an idea of the ischemic myocardium by taking this SDS divided by 68. So we can get to know that the difference between SSS and SRS is actually the ischemic myocardium, because on stress those segments are becoming ischemic. And so if the sum difference score is 0 or 1, it is no ischemia, 2 to 4 is mild ischemia, 5 to 7 is moderate ischemia, and more than 7 is severe ischemia. So this is how the SPECT MPI is interpreted. So why this perfusion is important? Because if we see the ischemia cascade, that the timeline, the changes which occurs when the ischemia starts, then before the symptoms develop in the patient, before that there is ECG changes, before there is systolic dysfunction in the echo, before systolic dysfunction there is occurrence of the diastolic dysfunction on echo, before that there occurs the microscopic metabolic changes in the cardiomyocyte, and prior to all these events we can see the perfusion defect that is seen in the case of SPECT. So this is basically the first ever known change which is occurring once the patient, when the ischemia starts. After SPECT, the next test is PET, that is positron emission tomography. So PET imaging is based on basically two concepts. First is the myocardial flow and second is the myocardial metabolism. So in PET scan, basically, first of all, it is performed with either rubidium or ammonia, which determines the myocardial flow. And second is, we also detect the metabolic activity with the help of 18 FDG that enters the cell with the help of LUT1 or 4 transporters, and this determines the myocardial metabolism. So the difference from SPECT, or the advantage from SPECT, is that the PET determines both the things. One is the myocardial flow, which is done with the help of this rubidium or ammonia, and second is myocardial metabolism, which is done with the FDG. And in this we do rest in that is rest, and again we inject the FDG, and then we wait for 60 minutes, and again then we check. So first with this what we are doing is for the myocardial flow, and this what we are doing is for the myocardial metabolism. So in interpretation of PET MPI, so first is we see that if we see that there is a perfusion defect here, and if we see that in 18 FDG the glucose metabolism is normal in that myocardium. So this basically tells us that the pattern of this is a mismatch, that there is no perfusion occurring, but there is showing that there is glucose metabolism which is occurring. So this tells us that this is basically a hibernating myocardium, and this will improve after revascularization. Second is no perfusion also and no metabolism also, so this is basically called as match, and that is that this is a scar basically, or a non-viable myocardium. And this is called as a partial mismatch, where there is a perfusion, there is a defect in perfusion, wall motion may be normal or abnormal, but the 18 FDG has a partial uptake, so that is a partial mismatch. That is in the case of a non-transmural scar. So the most important aspect of PET MPI is this mismatch, which tells us that the myocardium is still hibernating despite there is no perfusion, but there is glucose metabolism which is seen. And the last modality is cardiac MRI. That is cardiac MRI late gadolinium enhancement is basically the gold standard in viability assessment. As we know that the gadolinium accumulates in the area of the extracellular spaces, that is fibrosis or necrosis, producing hyperenhancement. While the viable myocardium, it washes out the gadolinium. So gadolinium is unable to cross the cell membrane of a normal myocyte. So as it is an extracellular contrast agent, it washes out slowly from the fibrosed or the necrosed or the non-viable myocardium, leading to late gadolinium enhancement. And there is also dobutamine stress CMR may be complementary for improved accuracy when probability of recovery is indeterminate. So LGE, basically the cardiac MRI does not infer the viability indirectly through perfusion or metabolism. The benefit of it is that it directly visualizes the myocardial architecture and fibrosis at the tissue level. So there is no indirect assessment of the viability. So this is the benefit over SPECT or PET. And transmurality of the LGE predicts the likelihood of functional recovery after revascularization. So based on which, if there is no late gadolinium enhancement, then it is fully viable. If 1 to 25%, then viable. 26 to 50% is mostly viable, and it has a likely recovery after revascularization. And if it is high, that is 51 to 75%, then the viability is uncertain. More than 75% is scar or non-viable. So this is basically direct visualization of the muscle. So as we can see that the normal myocyte there won't be any gadolinium uptake, so that will appear as black, and scarring will appear as white because gadolinium will accumulate in the interstitial and the fibrous tissue. So as you can see that this is entirely black. Here we can see that there is some 1 to 25% of scarring seen here. In this the scarring is 26 to 50%. Here it is 51 to 75%, and here you can see that there is almost more than 75% scarring in that area. So basically based on the transmurality of the scar, the thickness of the scar which is involved, we can determine whether viability is present or not based on the cardiac MRI. So basically these were the 5 modalities in which we can see the viability of the myocardium. So there are not much studies which have taken place. There is one trial, this is almost the largest trial which has been occurred, which has studied viability till date. So this is the STITCH trial, that is surgical treatment for ischemic heart failure. So in the trial they took total 1212 patients with ischemic cardiomyopathy and EF of less than 35%. And the coronary artery disease in the angiogram was suitable for CABG. Out of the 1212 patients, they were randomized into 2 groups, that is CABG plus medical therapy and medical therapy sub-study within the stitch also looked at viability. That is, 601 patients had viability testing done in the form of either a dobutamine stress echo or a SPECT scan, and divided into viable versus non-viable myocardium, and then checked if viability predicted who benefited from the CABG. So this was the trial which was done. First of all, the outcome was that if we see the all-cause mortality in both the groups, then it was significantly better with CABG, and CV death also was significantly better with CABG. This was done after 10 years. But if we see the viability results, then the viability status did not predict who would benefit more from CABG. Both the viable and the non-viable groups benefited similarly from the CABG surgery. So basically what was interpreted from the STIX trial was that CABG improves the long-term survival in ischemic cardiomyopathy with EF less than 35, but viability testing does not reliably predict who benefits more. So it suggests that CABG protects the remaining muscle from the future events rather than simply restoring the hibernating muscle function. So this trial, which was almost the largest trial for viability, was not effective. It didn't show any significant improvement by the viability tests. So what were the limitations of the STIX trial? First of all, the patients were not randomized for viability. Secondly, only 50% of the patients underwent the viability testing. Out of 1200, only around 600 underwent the viability testing. In viability test also, mixed viability tests were used, that is BAC and SPECT. So both have different sensitivity and specificity. So this was also not uniform. And lastly, the late gadolinium enhancement cardiac MRI, which is the gold standard for viability, that was not used in any patient. So basically this could not predict only whether the viability was really playing an important role or not.
So how many times we come across a hibernating myocardium with some other territory blockage?
Means the hibernating myocardium is of another territory.
Hibernating myocardium anterior wall માં છે પણ તમારે inferior wall block આવે છે, anterior wall માં significant blockage છે જ. આવું કેટલી વાર જોવા મળે છે? મળે છે કે નથી મળતું?
So that is not very common, which is seen. That if we see a wall motion abnormality of anterior, so there can be a misinterpretation in the echo, which may be possible, or either we must get a significant stenosis if there is a wall motion abnormality, or else the cause of that wall motion abnormality.
Viability testing માં hibernating જોયું કે આ સેગમેન્ટ માં છે પણ બ્લોકેજ તમારી બીજી આર્ટરી માં દેખાય છે ત્યારે એન્જિયો કર્યું ત્યારે એવું કામ અક્રોસ થાય છે ત્યારે?
No, so there could be a possibility that the other artery which has shown blockage, the myocardium may be viable, but if there is a hibernating myocardium, then there is a possibility that there has to be a stenosis lesion which is seen. So conclusion is that there is a lack of evidence to support that viability testing leads to improved survival in patients with ischemic heart disease, but it plays an important role in clinical decision making in many of these patients. That is, first is whether to go for revascularization or not in heart failure or late presentation of ISD. Revascularization strategy in complex multivessel coronary artery disease. Whether if there is a patient with a chronic total occlusion, and if we determine that the myocardium is viable, then we can take a risk of doing that PCI in that city. But if the myocardium is only non-viable, then we can avoid the risk of doing PCI and go for OFT in cases of chronic total occlusions. Then as we said, that the decision of valve replacement in patients with severe ischemic MR is important, and decision of valve replacement in patients with low flow, low gradient AS. And CRT, ICD decisions in ischemic cardiomyopathy, also the viability test helps us in guiding these decisions. And lastly is prognostication.